بسم الله الرحمن الرحيم. معكم الأستاذ الدكتور حسام صبحي، أخصائي الجراحة العصبية. نحاول بهذا السيشن تعريف الهيد تروما والمانجمنت، وإن شاء الله تكونون تستفادون في نهاية السيشن. وأي سؤال أنا حاضر أو توضيح، وأنا متواصل وياكم إن شاء الله. In this session, we will try to list the types of head injury, and also we see the secondary brain injury and the difference between secondary and primary brain injury. Also, we will list the severity of head injury types, severe, moderate, and mild, and we explain the medical and surgical management. Also, we will learn about the hematomas that occur intracranially due to trauma. Head injury is defined as any traumatic injury that involves the cranium and intracranial structure, that we are involving the skull or brain tissue. Traumatic brain and head injury are often used interchangeably. You have to know that maxillofacial injury is not a part of head injury. In order to know the pathophysiology of traumatic brain injury, we have to go back to the surgical anatomy, and you can see in this picture that the skull composed of layer, first layer skin, periosteum, and then the bone of the skull, and underneath there is the dura mater, which is composed of periosteal and meningeal layer. Downward we go to the arachnoid, to the pia mater, and then to the arachnoid villus, blood vessels underneath the arachnoid. We can see the box cerebrally between the hemisphere, and we can see the arachnoid space, epidural space, and the superior sagittal sinus. Head injury continues to be an enormous public health problem, even in the 21st century with modern medicine in the East. It is one of the most common causes of admission to the accident department worldwide. Most common causes include motor vehicle accident, fall, assault, sport-related injury, and penetrating trauma. Head injury occurs in all age groups, with peak incidence between 16 and 25 years of age, more common in males than females. Few points about pathophysiology. The brain is contained within the skull, which is a rigid and inelastic container. Hence, only a small increases in the volume within the intracranial compartment can be tolerated before pressure within the compartment rises dramatically. A second crucial concept in traumatic brain injury pathophysiology is the concept of cerebral perfusion pressure, which is the difference between intracranial pressure and mean arterial pressure. This plays a very important role in the pathophysiology of traumatic brain injury. Traumatic brain injury can be classified into closed or blunt and open or penetrating, and this classification depends on the type of injury, site of injury, pathology of injury, and the severity of the injury. This slide shows the difference between open injury and the closed one. In open one, we can see obvious external wound visible by naked eye, while in the closed injury no obvious external sign, and the main injury occurs internally within the brain substance. It can occur at tissue level or at cellular level or at intracellular level. Blunt head injury. A moving head strikes a fixed object, or a moving object strikes an immobile head, will lead to scalp injury, fractures of the skull, contused brain, or other injuries. Injuries resulting from rapid deceleration of the head, causing the brain to move within the cranial cavity and to come into contact with the bony protuberances within the skull. Non-missile blunt head injury can cause primary injury represented by Coup and Contrecoup, focal damage, concussion, contusion, diffuse axonal injury. All these are primary injury, while secondary injuries that can occur following blunt head trauma represented by concussion, epidural, subdural hematoma, edema, and infection. Post-traumatic complications that follow non-missile or blunt head injury can cause epilepsy, dementia, vegetative state, or coma. And in the slide seen to the right, we can see the post-mortal pathology of the brain with traumatic injury. We can see the Coup and the Contrecoup injuries. Penetrating or missile injury can be classified into two types according to the velocity. High velocity injury like pulse injury, and low velocity injury like knives, arrow, screwdrivers. The blast effect of high velocity projectile causes an immediate increase in the supracontural pressure and results in death because of impaction of cerebellum and medulla into the foramen magnum, while low velocity projectile increase the pressure at a more gradual rate through the hemorrhage and the development of cerebral edema. So the low velocity carries slightly better prognosis, and there is a time to manage the complications that accompany the low velocity projectile injury. Traumatic brain injury can occur at any site of the mentioned anatomical layers of the scalp and the cranium. It can cause scalp injury or scalp injury represented by different types of fracture, or it can cause brain injury with its many different types, or it can cause injury to the vascular system intracranially. Scalp injuries can be of either lacerations in which the continuity of the scalp will be disrupted and lost, or it can be in the form of subgaleal hematoma, in which the hematoma or bleeding occur underneath the galea aponeurotica, as shown in this slide. Skull injuries can occur in form of fractures, and the fractures can be either open fractures or closed fractures. Open fractures means that the scalp overlying the fracture will be disrupted or injured or opened, and we can see the fracture at the base of the or floor of the site of the injury. While closed fractures means there is no disruption of the scalp overlying the fracture and can't be seen as site of injury, but it can be visible if we open the skull to do craniotomy for evacuation of underlying hematoma. Skull fractures are significant clinical points. The closed fracture has a significant chance of associated intracranial hematoma, like epidural hematoma, which can cause mass effect and brain herniation, leading to a fatal or catastrophic outcome. In contrast, open fractures has less significant intracranial hematoma formation, but it have a potential for serious infection, and any foreign matter implanted in the skull or pulled by injuries inside the wound, it should be left in the place for removal by the neurosurgeon. If any person try to remove this foreign matter, it may induce catastrophic bleeding. So it should be covered lightly with a sterile dressing that has been moistened with sterile saline and left into place till the definitive management done by neurosurgeon. Morphologically speaking, skull fractures can be divided into either depressed fracture, which can be either depressed or simple depressed fracture, when the depressed segment will lie underneath the inner table of the skull, or it can be compound fracture when the segment of fractures disrupted from its attachment with the skull and lies inside the cranium, and it can be associated with disruption of skin, overlying skin, and with great contamination, and carries the risk of serious infection. Or it can be a linear fracture where there is no disruption of the level of the fracture, superior or inferior, but will be disruption of the integrity of inner and outer table of the skull. Another important type of skull fracture is the basal skull fractures, in which the fracture will occur at the base of the skull, and it has a significant clinical importance. These fractures can cause significant complications, so it is very important to know the signs that indicate the basilar fractures. If the fractures occur at anterior base of the skull, it can give to the sign of raccoon's eye, in which there will there will be bruises and pinkish discoloration around both eyes, resembling the raccoon's eye, so the name it applies. If the fracture occurs at the middle cranial fossa, at the base of middle cranial fossa, it can give to a sign of what is called battle sign, in which there will be bruises behind the auricle at the level of mastoid sinus. These both fractures, it can cause significant complication, in which CSF rhinorrhea occurs if the anterior basal fracture, or CSF autorrhea if middle cranial fossa fracture. Brain injury can be either primary or secondary. The primary injury is the initial damage that occurs immediately as a result of a trauma. It can be in form of concussion, contusions, laceration, or diffuse axonal injury, while secondary injury is the result of neurophysiological and anatomical changes which occur from minutes to days after original trauma. It may be due to cerebral edema, intracranial hematoma, brain herniation, cerebral ischemia, infection, or epilepsy. Cerebral concussion is defined as a slight distortion causing temporary physiological changes that leads to transient loss of consciousness, but with resultant complete recovery. Cerebral contusions is a more severe degree of damage with bruising and cerebral edema, leading to a diffuse or localized changes. Cerebral laceration is a tearing of the brain surface with collection of blood in different spaces and with displacement of dural parts. In diffuse axonal injury, this type of damage occurs as a result of mechanical shearing following deceleration, causing disruption and tearing of axon, and especially occurs at a gray-white matter interfaces. This slide shows the diffuse axonal injury that occurs from sudden acceleration deceleration forces that cause injury to the brain. It occurs at the area where the density difference is the greatest, so most tearing occurs at a gray-water matter junction, while in contusions changes occur at a more localized area with cerebral bruises and edema. Intracranial vascular injury can be in the form of epidural hematoma, subdural hematoma, subarachnoid hemorrhage, or intracerebral hematoma or intraventricular hematoma. Extradural hematoma is a hematoma in extradural space. Most common site is in the temporal region, and it results from the tear of middle meningeal artery. It's commonly present with lucid interval, and there will be features of raised intracranial pressure. Lucid intervals means there is a period of consciousness, the patient fully conscious, and after period of time there will be loss of consciousness, and this is very important to be noticed in head trauma, which indicates there is accumulation of hematoma intracranially. The feature of raised ICP will be headache, vomiting, maybe papilledema if we can examine the fundus, and eventually there will be loss of consciousness. If we do a CT scan, there will be a hyperdense lesion in the form of biconvex lesion or lentiform, or it's called lens shape. The treatment of extradural hematoma, it needs immediate surgical evacuation via a craniotomy. This slide shows us the pathology of extradural and subdural hematoma, and we can see the post-mortal state of the brain with the hematoma collected over the dura and causing severe pressure effect on the brain, and the surface of the brain can be seen contused and edematous. In subdural hematoma, the bleeding occurs between the dura and the brain surface. It occurs as a result of tearing of cortical veins, and it may be due to cortical laceration. It can be an acute hematoma or a chronic, depending on the age of the hemorrhage. Acute subdural hematoma usually present with loss of consciousness from the time of the injury, and it is progressive in nature, while clinical features of chronic subdural hematoma, it will include headache, cognitive decline, focal neurological deficit, and seizure. In imaging by CT scan, it will appear as a concave convex lesion. In acute one, there will be hyperdense lesion, crescent in shape or concave shape, and in a chronic one, there will be hypodensity, iso to hypodensity, also concave in shape. The treatment of subdural hematoma, if it is acute, usually treated by surgical evacuation via craniotomy, while if it is chronic, it can be treated by per-hole aspiration of hematoma. This slide explains the pathophysiology of development of epidural and subdural hematoma. In epidural hematoma, when there is a skull fracture, there will be turn of meningeal artery. This will lead to rapid accumulation of hematoma in the epidural space. This will push the dura and the brain away from the skull. In subdural hematoma, the dura, during injury, the dura moves with the skull and the arachnoid moves with the brain. As a result, the bridging veins are sheared and causing hematoma in the expansile subdural space. The hematoma will be gradually accumulated and causing pressure effect in the underlying brain and causing herniation and coning. In subarachnoid hemorrhage, the bleeding will occur in the space between the arachnoid space and the pia mater, that is the subarachnoid space. It may be due to trauma or it can be spontaneous, as in the intracranial aneurysm or arteriovenous malformation. Of course, this bleeding also causing raised intracranial pressure, which is sign and symptoms of vomiting, headache, blurred vision. To diagnose the subarachnoid hemorrhage, we can do CT scan to exclude mass effect, and it will show us the bleeding in the subarachnoidal space, in the interhemispheric fissure, in the Sylvian fissure. Also, we can do angiogram to see the leaking of the contrast from the turned vessels, and we can do lumbar puncture to see the RBCs within the CSF. To treat subarachnoid hemorrhage, we have to define the cause, to diagnose the cause, and we can do embolization of the aneurysm, or we can do surgical clipping by traditional craniotomy. Embolization can be done through interventional neuro radiologist without opening of the skull. That is minimal invasive surgery. Intracerebral haematoma is a hematoma that formed within the brain parenchyma. It is due to an area of contusion that coalescing into a contusional hematoma. In CT scan, it will appear as a hyperdense lesion and associated with surrounding edema and with mass effect and midline shift, as seen in this CT scan that shows a huge hyperdense lesion within the right parietal loop and causing obliteration of ipsilateral lateral ventricle with significant surrounding edema and with significant midline shift, with extension of the hematoma to inside the occipital horns of the lateral ventricles. Head injury can be classified according to its severity, depending on the loss of consciousness, amnesia, Glasgow Coma score. Minor head injury. There will be no loss of consciousness and no amnesia, and the Glasgow Coma score will be 15. In mild head injury, there will be a mild loss of consciousness and amnesia, with a Glasgow Coma score of 15 to 14. There will be impaired alertness and slight memory disturbance. In moderate head trauma, there will be loss of consciousness of more than 5 minutes, and the Glasgow Coma score will be 9 to 13. While in severe head trauma, there will be loss of consciousness, or patient will be in severe coma, vitally unstable, and the Glasgow Coma score will be between 3 and 8. Pathophysiological effects of brain injury. One of these effects is the brain edema, which is an accumulation of the fluid, both intracellular and extracellular. It is due to the congestion and dilatation of blood vessels. It may be diffused or localized in nature. Second effect is the brain necrosis, is of severe variety with destruction, and it is due to hemorrhagic infarction. Other effect is the brain ischemia, which is due to increase intracranial pressure. This increase in turn leads to alteration of perfusion of the brain, which itself aggravates the ischemia, and this forms a vicious circle or cycle, and it causing progressive diffuse ischemia of the brain. Coup injury, it occurs on the site of the blow to the head underneath the skull. Contrecoup injury occurs in a site opposite to the blow on the head. This slide explains the coup or Contrecoup injuries of the brain. The damage may occur directly under the site of impact, so-called coup, and on the opposite side, it's called Contrecoup. So the lesions or the damage will be one opposite the other. One of the very important sequelae of head trauma is the coning. And coning is the herniation of the contents of supratentorial through tentorial hiatus. It is herniated into the infratentorial region, so causing pressure on the brainstem and vital center, or the infratentorial compartment herniate through the foramen magnum and causing obstruction of the cerebral aqueduct and damage to the vital brain centers. clinical approach to the patient with head trauma. Very important is the history taking and then followed by proper clinical examination. In history taking, very important to know the mechanism of injury and whether there is loss of consciousness or not, or there is amnesia. Also, level of consciousness at time of accident and during transfer, or if there is any evidence of seizure and the current symptom. Probable hypoxia or hypotension, pre-existing medical conditions, if there is any allergy, especially bronchitis or allergic bronchitis or allergy to the drugs, or history of anticoagulant drugs ingestion. Evaluation of head trauma patient will depend on guidelines such as ATLS, also approaching the patient with ABCDE, and also it depends on the primary survey and resuscitation, also on neurological assessment and secondary survey. During the neurological assessment, it is very important to assess the level of consciousness for a trauma patient. This will depend on assessment the level of consciousness through Glasgow Coma scale. Also very important to know the reaction of a pupil to the light and its size. Of vital importance is the vital signs. Also, we have to examine the reflexes, the movement of upper and lower limbs, whether normal or abnormal. If there is weakness, and this weakness severe, spastic or flaccid. Also to see the response or posture of the patient limbs, whether flexion, extension or no response. During secondary survey, it is important to know the state of airway and protection of the airway, general assessment of other injuries, and looking for any associated injuries like abdominal organ injury, thoracic injury, fractures of upper and lower limb, presence for any scalp hematoma, fractures of skull bone which may be depressed, has to be looked for. Any blood from nose or ear, CSF rhinorrhea or CSF otorrhea to be noticed and to be looked for. Assessment of consciousness level through Glasgow Coma scale depending on 3 parameters, which is the eye-opening, verbal response, and base motor response. The maximum score will be 15 and lowest score will be 3, depending on these parameters to be examined and collected. And according to Glasgow Coma score, as we said, we can classify the head trauma into a minor, mild, moderate, and severe. We can plan the management according to this score, and also we can predict the prognosis according to the score. Pupillary response is very important in a trauma patient. If it is small but reactive, this may indicate diencephalic injury. If it is diffusely affected, there will be small and reactive. It may be due to drugs, metabolic encephalopathy. If the large pupils are large, fixed, it may be due pre-tactile injury. If it is dilated and fixed, there may be third nerve palsy as occur in truncal herniation. If it is in mid-position but fixed, it may be due to midbrain injury. If it is pinpoint, it may be due to pontine insult, as in pontine hemorrhage. Investigating the patients with head trauma, we can do a basic test like plain skull X-ray. We can look for fractures or relative position of the calcified pineal gland if there is any deviation of the shift from the midline. CT scan, non-contrast CT scan to look for cerebral edema, hematomas, midline shift, fractures. Look to the state of the ventricle and any evidence of brainstem injury. We can do carotid arteriography to look for any vascular injury. We can do MRI scan later on, not in the emergency state. Investigation for other injuries like abdominal and pelvic ultrasound. Also, we can do skeletal survey, cervical X-ray. We can do lumbar X-ray, dorsal X-ray, X-ray for the pelvis, and for the femurs if any hidden fracture. Of importance is to do monitoring of the intracranial pressure. Intracranial pressure monitoring is a very important aspect in the management of any head trauma patient. It can be achieved by introducing a catheter intracranially through either a fiber-optic device can reach intraparenchymal, that is in the brain substance, or by subarachnoid screws that perforate the skull and reaching to the subarachnoid space, and epidural or subarachnoidal catheter or intraventricular or intraparenchymal catheter can be put in the place, and this can be connected to the transducer and to device to monitor the intracranial pressure. This device or this steps is very important in management of patient with head trauma. So any rise in the intracranial pressure, we can detect it easily and we can manage accordingly. There are criteria for hospitalization of head trauma patient. These criteria are any altered level of consciousness, suspicion of skull fracture, alcohol intoxication, bleeding from ear or nose, associated injury, focal neurological deficit, persistent headache, vomiting, systolic hypertension and bradycardia, no CT scan available or abnormal CT scan of the brain. Treatment of mild head injury, that is the Glasgow Coma score between 15 and 14. There are criteria for discharge. We can discharge the patient to the home safely if the Glasgow Coma score 15, if there is no neurological deficit, and we can follow the patient at accident department or at emergency department to follow him. There are guidelines for performing CT scan. If the Glasgow Coma score at any point 13 or it is 14 to 13 within 2 hours of accident, if there is focal neurological deficit, suspected open or depressed or basilar skull fracture, if there is episode of seizure or more than one episode of vomiting. In moderate to severe head injury, the aim of treatment will be prevention of hypoxia, control of raised intracranial pressure, maintenance of perfusion, and other measures that treat other associated injuries and prevent secondary brain injury. It is of crucial importance that when we are dealing with patients of severe head trauma or moderate head injury, it is very important to control cervical mobility. We have to do cervical immobilization by using Philadelphia collar. And other important aspect in patients with severe head trauma is the resuscitation. And one important aspect is to maintain patent airway by using endotracheal tube or tracheostomy tube, so to secure the patency of airway. Medical control of raised intracranial pressure. The normal ICP will be 8 to 12 mm of mercury. To control raised intracranial pressure in patients with trauma, we have to put the head in 30-degree position. Also, we have to avoid venous obstruction in cervical region by putting the head and neck in a neutral position. We can use sedation plus minus muscle relaxant. Also, we have to do blood gas analysis. We have to maintain normal cardia in the blood of the patient. We can use diuretics such as furosemide or mannitol. We have to control the seizure. We have to take care about the temperature surrounding the patient. Should be normothermic. Also, we have to maintain normal sodium balance, and we can use barbiturate. The rendering reverse position is a suitable position for patient with head trauma. If medical treatment fails to control the raised ICP or intracranial pressure, we have to go to the surgical control. This is done by early evacuation of focal hematomas. We can do craniotomy for extradural hematoma or acute subdural hematoma, or we can do bare-hole aspiration for chronic subdural hematoma. Also, raised intracranial pressure can be controlled or treated surgically via ventriculostomy by aspirating CSF if there is obstruction to the CSF flow. Delayed evacuation of a swelling contusion, it can be done by craniotomy or by decompressive craniectomy. Head injury can be complicated by either early or late complications. In early complication, there may be brainstem injury due to coning. There will be compression over cerebellum and medulla and causing injury to the vital structure. Also, early complications include CSF rhinorrhea or CSF orthorrhea, which is in form of CSF leak. Late complication of head trauma can be the development of a chronic subdural hematoma. Early post-traumatic epilepsy, they need anticonvulsant for 3 years. Late post-traumatic epilepsy is due to scarring and gliosis of the cerebrum. Post-traumatic amnesia, post-traumatic hydrocephalus, and post-traumatic headache. These are all late complications of head injury. Grading of outcomes of the head trauma will be depend in also a scoring system. This score range from 0 to 5. 5 implies good recovery, while 4 mild disability, and 3 moderate disability, score 2 severe disability, score 1 persistent vegetative state, and score 0 patient will be dead. In summary, traumatic brain injury management, we have to consider these steps: respiratory support and ventilation by intubation. This will be of a great benefit to comatose patients unable to protect the airways. Elevation of the head 30 to 45 degrees. This will facilitate venous drainage. Straighten the neck and no tape encircle the neck. This also will facilitate venous drainage. Avoid hypotension, and systemic blood pressure should be more than 90 mm of mercury. This will prevent hypoxia and cerebral edema. Also, we have to control hypertension, because this will avoid the transmission of pressure to intracranial compartment. Avoid hypoxia, and PaCO2 should be less than 60 mm of mercury. This will prevent vasodilatation and result in cerebral edema. Control of ventilation, and aim is to maintain PaCO2 between 35 and 40 mm of mercury. This will cause vasoconstriction and avoid vasodilatation. Adequate sedation is important to reduce brain metabolism. We have to do brain CT scan to ascertain intracranial pathology rapidly. Thanks for your kind attention, and I am ready for any question in the Google Classroom. Best wishes.